Hello, everyone. I am sharing the results of a study I conducted as part of a dissertation for an MSc in pediatric palliative medicine. The aim of the study, entitled Learning from Bereaved Parents to Improve Children's Palliative Care, was to explore the experiences of bereaved parents with particular focus on advanced care planning, their experience of palliative and end-of-life care, and parents' perceptions and opinions on how such care could be improved. It was a mixed method study, with the first part being a questionnaire, which I will not be discussing in this talk. And the second part was a qualitative face-to-face interviews. The research questions were these and were expected to be answered by both the quantitative and the qualitative parts of the study. We recruited parents of children who had died of an life-limiting condition in the east of England between December 2013 and 2018. And the questionnaires were sent out to all those families in the register of the East Anglia's Children's Hospices. They were interviewed, and the interviews were analyzed using thematic content analysis with elements of interpretative phenomenological analysis. 12 families expressed interest. I had to exclude 3 because they were known to me. So in order to avoid any ethical conflict and bias, I excluded them. 9 interviews were conducted, 5 with couples. Most were done in the family homes. All were English speakers and white. Most families had high educational and occupational achievement, and they had been close to 2 years, but up to 5 years time elapsed since bereavement. The diagnoses were equally distributed between cancer, neurological, and perinatal, and the average length of the interviews were just over an hour. As you can see from this picture, the most frequent superordinate theme was around communication. Communication emerged as a powerful and essential tool to be used with care. And I will go into the major themes under this superordinate theme in the next few minutes, because this is what I'm going to focus on. But there were 2 other superordinate themes that emerged. And one was the impact of life-limiting condition on children and their families beyond the clinic. And these things we don't see as professionals. And the families talked about the emotional and behavioral responses evoked in themselves, such as hope, optimism, and where this could blend into denial, their fears, their need for trust, and their loss of trust on occasions, the impact that these conditions had on their personalities and their general outlook, but also long-term impact on their mental health, and the impact on their siblings. Families talked about the practical challenges they dealt with when dealing with medical and treatment complexities, but also, more importantly, when bargaining for services. They all had one story or another of having to bargain for services for their child. And they also felt that we professionals do not often see the challenges they have to face in life outside of the child's illness. Another superordinate theme were their priorities and how they wanted to be put in control. And amongst the priorities, the child's comfort, good symptom control, being offered a place of care and place of death, and focusing on the child's quality of life at all times were top priorities. They also wanted to have easy access to resources 24/7, appreciated advice and guidance on practical matters, especially surrounding death, and most families were appreciative of the hospice support they received. So coming back to focus on the superordinate theme around communication, I was sad to hear that most families found glaring deficiencies in our communication, and they found this extremely challenging. This was around sharing and understanding of facts, but also around the affective aspects of our communication, and both of which impacted on planning and shared decision-making. Families, almost all of them, found that we beat around the bush when dealing with diagnosis and prognosis, and they felt that we might be doing this in order to be kind, but in doing so, we were actually being cruel. And they felt that we need to talk to them clearly and repeatedly about prognosis without being beating around the bush and without just handing over a leaflet, etc. I will be not reading out these quotations, but these are really eye-opening, heartfelt words, and I would encourage you to pause the video and read them at your own leisure. They found factual information, when presented clearly and accurately, useful in making decisions for their children on their behalf. They also felt that in times of stress, they have to hear things repeatedly in simple language and explain what you did various things for. They were frustrated when we didn't respect their expertise about their child, when they had collected useful and priceless data about their children's response to treatment and their illness, but also about their quality of life, which is usually not visible in the clinic. They found it frustrating that we didn't talk to each other as much as we should. We didn't write down everything what they said, and we didn't plan and talk to our adult colleagues when it came to transition into adult care. They also felt that there was unnecessary hierarchy where junior doctors and nurses found it difficult to challenge senior doctors. They found our roles had too watertight boundaries, which limited our care. But most importantly, what affected me most were their descriptions of lack of empathy and lack of humanness in our behavior. They felt that we don't try enough to stand in their shoes, and many of them felt that nurses are often kinder than doctors. They pointed out that our communication lacked empathy, and they also appreciated it when they felt that we had human emotions as well, and that they could connect with us on a human level. They wanted respect, wanted to be listened to and not to be labeled. They felt they were sometimes just a number to us, and there were some really upsetting examples of where we forgot even basic courtesy and respect. Our words can have lasting impact, and they implode on us to use sensitivity in our words and what we do. They found sometimes atmosphere intimidating, especially when there are large groups of people talking in jargon, and also when doctors and nurses get flustered themselves, that makes the parents' anxieties worse. They wished we would plan better for uncertainties, and we would ask them what was important to them rather than giving them a form or asking them to choose between comfort and cure. Sometimes resuscitation plans hadn't been done even at the end of life, and parallel planning hadn't been done for unexpected improvement in the child's condition. Thankfully, none of these families experienced distress needing intervention, and some even reported that the interview was very helpful to themselves. My study obviously had lots of limitations, the small sample size being the most important one, but also the sample had diagnostic heterogeneity and sociocultural homogeneity when it should have been the other way around. There obviously was some recruitment bias because these were self-selected parents returning my questionnaire, and there was recall bias because of the time elapsed. My biases would undoubtedly have crept into the analysis as well. In all, the research questions I felt were not adequately answered by the study. But one thing was clear: communication, most importantly listening, is very important to families. The clarity and honesty in our communication and the willingness to plan for uncertainty. We need to be more sensitive, more empathic, more compassionate, and more respectful. Could doctors learn from nurses? Could we use hospices more? There are a number of practical challenges outside of the child's illness and emotional burdens that the illness brings, and professionals need to be aware of them. These glaring deficiencies in planning and communication highlight the need for better training for pediatric doctors, nurses, and allied health professionals in communication, but also in palliative care in general, including advanced care planning. Needless to say, families need better access to palliative care services. But I was reassured that carefully and sensitively conducted research is feasible and safe in children's palliative care. I said I won't read out the quotations, but I think this particular quotation sums up my study, and it's important that it be read out. A dad said to me, "And I think you're going to be a doctor or a nurse because you care, because you have a passion. You're obviously very bright people and you want to use your gift of knowledge to help others. But sometimes, and in my experience, it's more the doctors than the nurses, that you lose that sense of personal contact and the ability to empathize, become so wrapped up in the clinical side of things. And I suppose see this all the time, deal with these situations all the time, just like robots. Don't see the children as children, they're just a case, and don't see the family, they're just, I feel, a hindrance." Thank you.